Perfect.
Oh, Bios is here. That's nice. Ah, Jen. Hey, Bios.
Hi, hello, hi everyone.
Nacho, you will be introducing Bios, right?
And yeah,
Okay,
yeah, we do that. I think it's going to be good.
perfect.
Okay, that's nice. Good, good, good. Mhm.
It was also difficult because of the time changing. I was assuming everywhere around the globe was changing the time, but I think it's not the case. It's not for you, Patricio, isn't it?
Within a week, we will change the frame time.
Yeah, exactly.
Okay.
But I think that the key for next time is to send it with the Google link or something that changes automatically from the beginning. Because
Yeah, it could be.
if we only give the Zoom, it's but I mean it's going to be difficult anyway
Yeah.
to put everybody together. Okay, guys, so I think we're going to start because I see now we are now 25, which is a very good number already. If people are coming, we will keep on admitting them to the webinar. So first, officially welcome everybody. Thank you very much for taking the time for being here today to discuss the best of ECCO in Stockholm for those who could attend and couldn't maybe attend all the sessions or miss some parts. And also for those of you who couldn't make it, I think it will be a very nice discussion. We have great panelists here. And we are very happy that the Yogi project is ongoing and growing. And this is the first webinar of the year. We are very happy. We are very happy to welcome you. And of course, just to remind you that this should be an interactive webinar and that all questions or comments are allowed and very welcome. And just use the chat or raise your hand and we'll try to do our best. A bit difficult to navigate it with this Zoom thing we have and see everybody, but I think we can go and check the chat and keep on admitting people. So thank you very much for taking the time. And let me introduce Bea. If there's anybody in the IBD world that doesn't know Bea, welcome, Bea. Thank you for joining us.
Good afternoon, Nacho. Thank you very much for the introduction.
So I think we're going to start, Bea. Do you want to start? So I think we have now. Okay, this is growing. We have 32 now, but let's move. Let's go.
Yes, exactly. So as Nacho was saying, just remember that many of us, including ourselves, may have missed some of these talks because it's too crowded and there are so many rooms running in parallel, and perhaps we have doubts that we can discuss in between us, and or perhaps comments that we would like to discuss afterwards. So feel free to write everything on the chat, or afterwards you can ask directly. And with this, we have three different sections. The first one is the best of ulcerative colitis, that is presented by Maya Fishman. I know many of you may already know her. She's a fantastic clinician working in the Rabin Medical Center in Israel, and she is a very hard worker and really a fantastic person, other than a very good professional. And with this, Maya, the floor is yours. Thank you very much for all your hard working.
Thank you, Bea, for this wonderful introduction. I can't seem to beat it, but thank you very much. And thank you, Yogi, for having me. I'll just share my screen. So let's see. Continue to share. Do you see it now?
Yeah.
Perfect. So good evening, everybody, and thank you for joining us. As Bea said, I'm Maya, and I'll be briefly describing the best of UC on the recent ECCO conference. So we'll start by a few abstracts that caught my eye on the field of diagnostics and monitoring. We'll start by this nice study describing the role of calprotectin in ulcerative proctitis. So we all know calprotectin as a reliable marker for UC, but what this study highlights is patients with proctitis who are often excluded or disregarded in terms of large UC studies. And what this group nicely did was an observational study of patients with quiescent proctitis, and they followed them for 1 year. And they saw that in the relapse group, which was about 16% of all patients, calprotectin was significantly higher in the relapse group, which is perhaps not a surprise, yet is always nice to see. But what was interesting, in my opinion, was that the cutoff for distinguishing relapse and non-relapse in proctitis was around 40 micrograms, which is much, much lower than the threshold we usually talk about UC, which is around 150, and the NPV was around 91%. So I think it's a nice study to start off our talk with, actually understanding that the threshold for suspicion in proctitis should be perhaps lower than expected. Next, we move to the role of anti-alpha V beta 6 as a predictable marker for patients with preclinical UC. So this Swedish group took 4 population cohorts. 2 were used to do as a discovery and validation of this anti-integrin autoantibody, and 2 were further used to establish the role of alpha V beta 6 throughout life using birth cohort and twin cohorts. So what they saw was that this anti-integrin is elevated in preclinical UC patients versus healthy control group with high specificity. And this was also revalidated in the second cohort that they use, in a large population-based cohort throughout the serum. Then they asked how early can we detect the anti-alpha V beta 6 antibody, which was even more interesting because when you look at the birth cohort, you can already see that this antibody is actually rising even in newborns, which is amazing because you can see that even 20 years before diagnosis, you can already see it. And when you look at a lifetime, you can see the levels continue to rise up until diagnosis. They looked whether it's related to genetic or environmental factors, and they saw that actually there was kind of low twin pair correlation, and it was not influenced by smoking, which is one of the greatest environmental factors related to UC. So it's also interesting. And lastly, they looked if anti-alpha beta 6 correlated with any other known proteomics and proteins related to inflammation in UC, such as CXCL8 and stuff like that. And they saw that it does have a co-abundance, meaning that it might be a part of a larger inflammatory complex. So this is nice. I think they did a really large study to show that anti-alpha beta 6 is actually a preclinical biomarker for UC in undetected patients long before diagnosis. And this leads us to treatment optimization, but we are still with our beloved anti-integrin antibody. And in this group, they actually used the same anti-integrin to check if it can predict response to treatment for patients under treatment of vedolizumab. So they used post-hoc analysis of a cohort of patients with IBD, both Crohn's and UC, and tried to see whether anti-integrin levels predicted response. So first of all, they saw that it's a really good discriminator between UC and Crohn's. As you can see on this slide, you see that it has a really higher levels in UC patients versus Crohn's with really high sensitivity and specificity, which is interesting by itself. Then they measured the anti-integrin levels both at the baseline and at week 6 after starting vedolizumab, and they saw that among responders and patients who remained in remission at week 52, you can already see a decrease of 30% or more in the anti-integrin levels. And this drop was seen only among the responders group, and the non-responders did not experience the same drop. Then they tried to recreate it with patients under the treatment of golimumab, and they did not see a similar trend. So it wasn't a good marker for that, but it is really promising as a marker to early predict response to treatment. And as you can see, a high decline in the serum of this anti-alpha beta 6 can actually predict 1 year of response to treatment under vedolizumab. Another interesting study in the field of treatment optimization is the Tactic QC, which was led by an Italian group, including our very own Luisa Burdin. And this study, I think, is really nice because it actually brings to life one of the concepts that we always talk about in Stride about what is treat to target in UC, and that we should opt for histologic remission and not only be satisfied with clinical response. So Tactic QC actually wanted to assess whether this approach is really working for us. So they included 140 UC patients who had milder quiescent symptoms in terms of clinical remission, but still had moderate to severe endoscopic activity. And they had 160 events of optimizations. And they looked at both endoscopic and histologic outcomes, and they saw that in the optimization group, you had a really high response in all fields, both endoscopic and histologic improvement and remission. And then they asked in the field of, in this cohort, which patient have benefited the most from this treat to target approach. And they identified that patients that had no baseline treatment with steroids with a moderate endoscopic score, meaning a score of around 2, not higher, and under anti-TNF therapy were the ones who benefited the most from this treat to target approach. And I think it really embodies really nicely the fact that we should pursue treating up until the endoscopic and the histologic remission and not only be satisfied with clinical symptoms. Two novel approaches in therapies that I liked. The first was the Anthem-UC. It's a sequel because the first one was already published. It's a phase 2 trial of the first oral IL-23 receptor blocker. I think it's a really promising drug because I think it's a nice alternative to offer patients who often seek an oral medication and not injections. So this study already showed that icotrokinra has a beneficial clinical improvement at week 12, which was sustained up until week 28. And what was nice about this abstract that was presented at ECCO was that they asked not only about clinical remission, but also what are the systemic and tissue inflammatory effect of icotrokinra. So they used the same RCT, and they showed that icotrokinra by week 12 achieved a significantly lower rates of serum inflammatory markers, including CRP and fecal calprotectin, but also serum markers of cytokines such as IL-22 and IL-17 that we know that are related to the IL-23 pathway. And what was even nicer, in my opinion, was that they also have shown a tissue effect of actually how icotrokinra is changing the transcriptome in the colon. And they show that in the UC patients before treatment, there was an upregulation of inflammatory cells-related genes and decrease in downregulation of barrier integrity genes. And after 12 weeks of treatment with icotrokinra, you can see that the trend has flipped and changed. And now there is an upregulation of barrier integrity and epithelial repair. And I think it's a nice approach, when we have so many available RCTs and clinical data. I think it's nice to see how the new drugs work on a tissue level and not only on the clinical level. So I like this study. And another one was this Chinese RCT, which was studying the option to do a combined induction of both UPA and vedolizumab versus only vedolizumab in patients with moderate to severe UC. They called it the hit hard and fast strategy because, as you know, UPA has a really rapid onset and rapid relief of symptoms, but we do have some concerns about it and the safety profile long-term. And vedolizumab, on the other hand, is gut selective and has really preferable safety profile, but on the other hand, it takes time to kick in. So what they did was doing an 8 weeks of combined therapy versus vedolizumab alone, and you can see that both clinical endoscopic and even histologic endoscopic mucosal improvement was higher in the induction group after 8 weeks of treatment. What is interesting, in my opinion, is that group is continuing the study to do a 1-year follow-up on these patients. And I think it will be interesting to see if the 8 weeks induction not only improved the 8 weeks outcome, but also achieve sustained remission and higher persistence of vedolizumab, which can, I think, certainly be changing in our practice if it would turn out nicely. So this is something to look forward to and pay attention to in the future. And last but not least, my favorite topic, so I saved it as the best for last, is surgery in UC. Here we have really interesting study about when we sequence elective colectomy. I think in the era of the abundance of medical therapies, we tend to kind of defer the elective colectomy option to our patients with UC because we have more and more options to offer them, even if they fail on several treatments. And this study wanted to ask, are we doing them any favor, or should we perhaps think of colectomy early when it's still elective and not wait until it's urgent and unavoidable? So they used a nationwide cohort and they identified 2,300 elective colectomies, and using propensity score matching of 1 to 3, they compared elective colectomy to patients with UC or continued medical therapy, and their primary outcome was all-cause mortality. And they saw that 10 years and 20 years mortality rates were significantly lower in the elective colectomy group versus the medical therapy group. Once again, they asked which are the patients who would most likely benefit from early elective colectomy, and they saw that both patients who had use of steroids in the past year or patients who had hospitalization of over 7 days due to their UC in the past year, as well as adults, patients who are age 60 or higher, are more likely to benefit from elective colectomy. And I think it's a great reminder that surgery is nothing to be afraid of, and we should also keep it in mind when offering our patients sequence therapy. And finally, the 5-year follow-up of ACCURE. Just as a reminder, the ACCURE was an RCT study of both the British and Dutch population, comparing appendectomy versus control in patients with a remission of UC. And in the primary study, they have shown that appendectomy had significantly lower rates of relapse in the first year post-surgery compared to the control group. So here in the 5-year follow-up, they focused only on the Dutch cohort. They had 160 patients who were all at remission in baseline, meaning only the population that after the first year of the original trial still were in remission. They had 80 appendectomy and 83 in control. And they wanted to assess after 5 years how many of them needed advanced therapy. And as you can see, the rates were surprisingly low, amazingly low. You can see the HR was 0.33 in favor of the appendectomy. Secondary outcomes, including colectomy and dysplasia, were null on the appendectomy, yet still, due to very low cases in the control group as well, it did not reach statistical significance. And lastly, during assessing the endoscopic remission, they did have higher rates of endoscopic remission in the appendectomy group, but they did say it was limited because most patients in the cohort did not undergo endoscopy, so we're not really sure because it's only a third of the cohort. Anyway, I think it's a great study to end up with, because for me it leaves me with a lot of questions about how we offer our patients appendectomy, when we offer them. And I think, with this data of the ACCURE after 5 years alongside the COSTA trial, I think it's becoming more and more prominent and promising. So I'd be happy to hear from you guys if you're implementing in practice or have any thoughts about it. And other than that, I just want to thank you all for listening, for joining us. Once again, thank you, Bea, Nacho, and Yogi for inviting me, and hope you liked it.
Thank you,
very
Maya.
much.
It was fantastic, and this is surprising how good you could summarize so many studies. And I agree with you. So many of these, I found them like the best ones. So congratulations, Maya, and thank you very much for the big effort of putting all this together. And Nacho, you are next, right? You are going to introduce.
Yeah, and I was wondering if there is any burning questions or comments. There's a lot to talk about that, from the very polemic and interesting things like treat to target, and of course the role of surgery, both colectomy and appendectomy. So we can have some discussion later, but let me see. I think there's a question here. I don't know if you can read it, Maya.
Yeah, I just read it, and actually it's a great question. I think the original presenter was also asked the same questions exactly during the conference, because I agree that UPA, for all its benefits, does have really a quick and high response rate. So I think, it's a nice concept study. I think the concept of combination therapy is becoming more and more prominent. So I definitely agree that the added value should be compared to UPA alone. which they didn't show in the current study, but the original presenter said that they do have another arm and they are planning to see whether it affects the vedolizumab persistence in the long term. So, even if using UPA as a starter and then having the vedolizumab kick in, it can be interesting, but definitely a great question because, makes you think.
Yeah, no, I think it's very interesting because it looks like the new version of combo therapy, right? So one fast runner and one long-term runner, and see how it works or see if it. I think it would be very interesting, like you said, to see what happens. See if it's possible to leave UPA later and then use different strategies for induction and then remission, be more conservative in remission, and maybe go for more heavy induction. Let me see. Seb, you want to comment since you put the comment on that? And I would really like to know your opinion, Seb, about the appendectomy in patients in remission. Are you putting it on the table today in Hull, or is it something that we still have to wait to see if it's a viable option to be implemented in practice?
I mean, it's emerging data. Both the studies are very good, but as you know, there are some nuances relating to that. We need to do which specific groups they are going to respond. There is a global study which we are part of at the moment, setting off in relation to appendicectomy, both as a cohort and also as a patient preference design that is going to get going. Again, will be led by Christian Busken. So it is, but there are nuances, particularly in relation to, is it conventional appendicectomy or actually getting the apex of the cecum along with that? Is it the group who is the best group which benefits from, in my humble opinion, the ones whom I really want to study are those who have refractory proctitis, medically refractory proctitis with a PAP, very appendiceal patch, and those without the patch, that would be this thing. It may be difficult to power it, but it is something worth this thing. But it's a interesting concept. We are definitely part of the observational study, but at the moment not given outside the study setting.
Interesting.
I think the UPA thing is a really good, but what you need to really think of UPA is, can we use it as a pulsed treatment? Okay. And then have much lower toxicity and lower cost at the moment drugs. Combination is a good idea, but to me, it is like substitute the steroids.
Do you consider an option to use the TOFA now that maybe it will be cheaper as a bridge as well, or do you have more faith in UPA, Seb?
Again, there is a global study which is just launched. You're very welcome to participate in it. It is actually observational across all the 3 JAK inhibitors, which is important, I think, because as you know, translationally, JAK-STAT pathway is different across ethnicities. So there are some translational work as well as observational study going on, and if you are interested, to reach out.
Thank you. Well, thank you, Maya. Maybe we go back to one of these questions after that. So let's move on. It was a fantastic presentation. Thank you, Maya, very much. Now we are presenting our second speaker. Also, of course, a young IBD rising star, if not rised already. It's Nathan Grelier. He's working in Saint Antoine in Paris, France. And he's gonna give us his personal summary on the best of Crohn's in ECCO. Welcome, Nathan. Thank you for joining, and please.
Thank you, Nacho. Thank you for this kind of introduction. So, at least I'm gonna present you my top 5 presentations from ECCO. I know that all of you cannot see all the presentations and everything that is going around ECCO, but I tried to cover all the types of presentation about Crohn's disease, and I tried to look at perianal disease, ultrasound, and structuring disease. So First, I wanted to talk about the results from Nuru with the long-term follow-up from the profile trial. So, as you all know, the profile study was published 2 years ago with the outcomes at 1 year about the step-up treatment versus top-down strategy. So it's an RCT with newly diagnosed Crohn's disease, and the top-down strategy was infliximab in combination therapy with thiopurines, and step-up treatment was corticosteroids and thiopurines and so on for patients. So Nuru told us that at 1 year, the patients with top-down strategy required less surgery and less complication from Crohn's disease. But here he tried to assess the risk of surgery at long term. And here you can, the results of pretty straightforward. When you look at the risk of surgery, in blue, you have the top-down group, and you see that the top-down strategy required less first abdominal surgery compared to step-up treatments. And when you look at the other outcomes of the study, so disease progression to B1 to B2, B3, and hospitalization due to Crohn's disease, it's clear that a top-down strategy is better than a step-up treatment. And when we asked the question of safety outcomes regarding top-down strategy, Nuru showed that they had similar safety outcomes and in terms of infection and other outcomes. So very, very important results from the profile long-term follow-up. Then I tried to look at every studies about ultrasound, and I think that this one reflects well what could be the next designs from clinical trials with ultrasound and non-invasive markers. And here it is a study presented by Professor Anthony Buisson from France, and it was symptomatic Crohn's disease patients with objecting sign of inflammation on ultrasound. It was a multi-center prospective study in France, and here he showed the first results from the Skynetics study. So Anthony showed us the rates of transmural healing and transmural response in patients treated with risankizumab in a real-world setting. And the ultrasound was led by experienced IBD sonographer with usual ultrasound outcomes. So the primary endpoint was the transmural response according to IBD-SAS at week 4 and 12. Here you have the rates of clinical response and clinical remission after risankizumab. And here you have the primary endpoint, and he showed us that nearly 1/3 of the patients had transmural response according to the IBD-SAS score on ultrasound. And he showed us also that those transmural response was not consistent according to ultrasound score definitions. So IBD-SAS, BUS score, US Clermont score. So I think it's a good study to learn from, thanks to the study design, the non-invasive examination used in that kind of studies. And I think it is the future for Crohn's disease study design using only non-invasive examinations. Then I wanted to show you the nice talk about the perianal disease and the top class consortium. So Professor Philippe Tauser tried to show us what could be the next target to have in perianal disease according to the recent top class consortium classification. this slide only to remind you what kind of perianal disease we have according to the class. So class 1 minimal disease, class 2 chronic symptomatic fistula, class 3, so patients become more refractory with stoma, and class 4, it is patients that relapse their perianal disease even after proctectomy. And so they led a Delphi consensus between clinicians and also with patient components. So they try to define outcomes according to the timeline of the treatment response. So early outcomes should be at least an obviously symptomatic response. So no abscess, no septic perianal disease, acute disease control. So midterm target could be stabilization of symptoms improvement, radiological improvement, and late outcomes could be functional remission. So they try to define what could be the functional remission, and obviously it is patients with chronic perianal disease that is difficult to treat, but we try to have like very practical outcomes and try to improve their daily life with functional remission. And here you have all those different targets that we can have and that we should thrive for patients with perianal disease class 1, class 2A. I won't be specific, but here you can see that at least class 1, it's no symptom progression. For class 2A, cytin removal and so on. But I think it is really interesting to have a new treat to target in perianal disease and to have a consortium that defines that. For the third study, I wanted to talk about stricturotomy and endoscopic stricturotomy. So the great talk from Parthapal about endoscopic approaches for Crohn's disease strictures. So he showed us great movies about the novel technique of stricturotomy. So it is whether radial incision or segmental layered incision with a circumferential endoscopic dissection. So he showed us great movies with very practical videos and show us how it can treat. Here you have a colonic stricture, so it is very interesting technique. And then he showed us the results of his study. So it is the best CT trial comparing endoscopic balloon dilation in 50 patients compared to endoscopic stricturotomy. So it was a randomized trial with short strictures that could be ileum or colonic strictures. It was a single center study, but he showed us that they used endoscopic stricturotomy technique using needle knife or insulated tip knife for the stricturotomy. And here you have the primary outcome of his study. That was the time to clinical recurrence after stricturotomy. And in red, you have patients treated with stricturotomy, and in blue, patients treated with balloon dilation. So he showed us also the other outcomes, that was surgery requirement and of course safety outcomes. And it seemed that endoscopic stricturotomy is a very promising technique that could be better than balloon dilation for short strictures in colonic disease or strictures from the ileum. So very, very interesting talk from Dr. Pathopal. And to finish, because obviously I'm from Saint Antoine Hospital, that we study a lot the microbiome. I wanted to talk about the nice talk from Professor Ari Sokol that showed us how we can treat IBD by targeting the microbiome. So first of all, Ari began his talk by saying that FMT is very difficult to scale as a therapy, because a number of limitations due to donors, due to receivers, and he showed us that the more you go to a single strain therapy using bacteria, the more the more scalable it is, and the less complex it is to test. He showed us that with the Saint-Antoine team, he showed us that they isolated Faecalibacterium prosnitzi, that is a predominant species in healthy human, and it is now established that it has anti-inflammatory effects on the intestinal barrier. And Professor Sokol showed us his first result about XL1 Faecalibacterium prosnitzi, which is so the name of the strain. In this study, it's a phase 1 proof of concept study. He showed us that Faecalibacterium prosnitzi could be used as a treatment to maintain remission in Crohn's disease. And here in this proof of concept study, they use corticosteroids to induce remission. And when they begin to taper the steroids, Faecalibacterium prosnitzi was used to maintain the remission. And it was only a small study with 8 patients, but actually it is a safe treatment, and we have a phase 2 randomized control trial ongoing to evaluate its effect in preventing postoperative recurrence in Crohn's disease, and also in other type of intestinal disease such as Clostridium difficile. So very important concepts about microbiome treatment, and we're looking forward for these results. So with this, I would like to thank all the Yogi group for this invitation, and I will be glad to answer your question. Thank you.
Thank you very much, Nathan. Very, very nice presentation with a lot of novelty and a lot of interesting things. Is there any question from people listening, Burning, or from any of the audience?
Hi.
Hey, how are you, Luisa?
Hi, I'm Luisa. Nice to meet you for all who don't know me. Thank you, Nathan, and thank you, Maya. They were wonderful presentations. I just loved both. I have a question for both of you. So for Maya, I will go back to Upanvedo because I think it's so interesting, the study. We are doing it a little bit, I'm not sure if I can say, on pregnant women or women who would like to get pregnant, because as you know, UPA or anti-JAKs are not safe in pregnancy. Well, Vado is, and sometimes for very aggressive disease, we're induced from remission with an anti-JAK and then maintaining it with biologic. And do you think this is an approach that could be used or could be tested in the future? Like with other drugs like mirikizumab or just guselkumab. What do you think about it? And for Nathan, I know you work in the Sant' Hospital. We also do some microbiome, some FMT, but I really envy like so-called the experience. And what do you think that will be like microbiome therapeutics in Crohn's disease in 10 years from now? What's your insight about that? What do you think? Thank you both again.
Thank you, Luisa.
I'll let Maya go first. Yeah, go on, Maya.
Yeah,
Thank you.
Nathan's question was so difficult.
I'm taking some time to think.
Yeah, exactly. Well, it's great to see you, Luisa.
You can say something back in once.
So, Luisa, thank you, and it's great to see you. And I'm glad to see that the UPA and vedolizumab got a lot of traction, and I feel like this is the main focus. I think it's really interesting in general, how will we use JAK inhibitors in the future, because they have such a prominent rapid response. And I think Seb also mentioned it. It's kind of like steroids in the terms of like you can do a pulse of JAK inhibitors and see whether or not it can help, like you said, in achieving quick remission in patients, pregnant patients or patients that are wanting to get pregnant, or in acute severe colitis. And I feel like, once we have more and more data, we can be more reassured that we can use it maybe, as a bridge when introducing new therapy to patients to achieve better relief of symptoms at the beginning of the treatment. And perhaps, I think the most interesting part is, whether this short course really can change and alter the long-term outcomes, because, for 8 weeks, it works because we know it works really fast. But I think in the long term, to see if it helps, can really repurpose it as an introduction drug, an induction drug to a lot of cases. So Nathan, the floor is yours. What do you think about FMT in Crohn's?
So, what Harry told us, and I think what he taught us is that FMT is a complex treatment to implement in terms of cost, in terms of scalability. And if we want to have a microbiome-derived therapy, I think what he taught us again is to have something that could be produced in a large scale. So that's why he always say that it depends on if you have a single strain bacteria, a consortium of bacteria, and FMT. And according to the model of the pathology, so it depends on the disease. So there is FMT for IBD. It has maybe a place to induce remission, but in the long term, FMT is difficult to implement in a clinical routine. So maybe the treatment with a single strain bacteria or single strain fungi could be used if it is producible in a larger scale. So I think we're at the step where we have to show efficacy of that kind of strains, and we have to produce all those data and to show that it works or not, because there were negative results about probiotics. So I think we have to try and then wait for the results.
The good part is, I think those type of therapeutics are very safe.
Yeah.
So many patients would prefer such therapy, such as diet, maybe.
Yeah.
And I see them as an adjunct. My question was maybe a little vague. I'm sorry. My question was like, do you see them as an adjunct to like diam, or adjunct to another biologic or or a small molecule, or do you see them like in mild Crohn's therapy, which is like a field of nobody? Sorry about the question, was really vague.
That's why Harry is leading the maintain pub study. So maintain pub study is the study that evaluate Faecalibacterium prausnitzii to prevent postoperative recurrence. So with the bacteria, patients can have an anti-TNF, and so in the analysis there will be patients with post-op treatment, patient with no anti-TNF treatment, and we'll see the stratified results, the stratified analysis according to anti-TNF or not, the bacteria or not, and we'll see if there's any difference. But maybe it can be used as an adjunct treatment to help with the immunomodulatory effects that our lab showed in vivo models already. So maybe as an adjunct treatment and a supplement, maybe.
Yeah, thank you for the answer. It was really interesting.
Thank you, Nathan.
Thank you.
If I can add a comment on FMT, I think I have always two thoughts. The first one is that FMT is probably more useful in maintaining remission than in inducting. So I think we should focus mostly on inducing people with some of these quick drugs that we talked about, and then maybe use it to keep the dysbiosis in place. That is the first thing that I think we should focus on maintenance, and I think it may be in prevention. I think that could be a good scenario for those who are at risk, and we're going to see in Intercept in other courts and in Promise. But it will be promising to use it. And the second comment is that I think there's too much focus on bacteria. I'm always wondering what we use in FMT. I mean, is it that we are disbalancing the Candida populations? Is it that we are using bacteriophages? Is it something that is not even the microbiome? Is something floating in the feces like IgA that is anti-inflammatory? So I think it's very mysterious. But I understand that bacteria is, of course, probably the main driver, but I think we shouldn't lose that sight of FMT is a very complex thing because you put an entire ecosystem there, and we are not sure of what is working. But of course, very, very interesting to see if one of these single strain can be useful as well. For the sake of time, let's move on. We have the last speaker for today, Svaios Svolos. He's a dietitian, and we are very, very happy to have him here from Greece. The idea of yogi is also to be multidisciplinary, and we are also showing here that we try to be, and we would also like to include more surgeons and even psychologists. There's actually some psychologists here in the webinar today, so we are very happy about that. So welcome, Vios. It's a pleasure to have you here and give us some light on diet and IBD. It's a very hot topic. Thank you.
Thank you so much for the introduction, and thanks for having me here today and for the invitation. So I will try to, for the next few minutes, to give you some updates on some dietary concepts and dietary studies and presentations that took place at ECCO Congress 26. So I've got a list of 5 different presentations I'm going to talk about here today. So I'm going to start with a study which looked at the combination treatment of adalimumab with partial enteral nutrition. The study is being happening in Scotland and compared adalimumab monotherapy in adults with active Crohn's disease compared to adalimumab combined with partial enteral nutrition. 101 participants were randomized in this study. You can see about 80 participants have completed it, and they were split into being biologic naive, into receiving either adalimumab alone or adalimumab with 50% covered of their daily calorific intake from partial enteral nutrition. If you look at the primary outcomes, you can see that there are no differences in percentage of achieving remission or response at 12 weeks between the 2 cohorts. However, there was a trend about differences in achieving response at an early stage at 6 weeks within this population. And when the team has looked into a sub cohort of the patients who had high CRP and high fecal calprotectin at baseline, and they could pick up a significant difference in a percentage of people achieving response at 6 weeks. There was a trend in the percentages at 12 weeks, but this was not statistically significant. Interestingly, also the therapy combination of partial enteral nutrition with adalimumab seemed to be more efficacious when they looked into people with ileal disease compared to those with colonic disease, something which has been described from pediatric studies in the past about enteral nutrition. In this study, the amount of enteral nutrition covered, the amount of calories of enteral nutrition covering the energy intake seemed to associate with the CDAI levels at the end of therapy. And also there was a trend about, an interesting trend about differences in the percentage of patients with detectable anti-drug antibodies at 12 weeks within the group of combined PEN, partial enteral nutrition, and adalimumab. And very interestingly, in a small cohort of those patients, there was a difference in those patients achieving at least 50% decrease in CES-CD. So there were colonoscopies in a small sub-cohort of the patients, and there was much higher percentage of people achieving a 50% decrease in CES-CD among the adalimumab plus partial enteral nutrition cohort. Moving on and following the momentum of prevention and looking into how we can reduce the risk of people developing IBD. I think that the dietary studies are also moving towards this direction, and I'm presenting you here from the Pioneer data from the Pioneer study. So this is the tasty and healthy whole food diet, which has been tried here in order to improve calprotectin levels in first-degree relatives who are at risk of developing Crohn's disease. So we have here first-degree relatives who have a high level of calprotectin and have been treated with this dietary intervention. Tasty and healthy is a whole food diet, which is not including any enteral nutrition, and it's excluding foods which are processed and canned, foods including gluten or foods containing animal fat coming from meat or dairy, and includes a number of other naturally sourced foods. So in this presentation, we saw that the researchers have screened 950 healthy first-degree relatives for elevated fecal calprotectin, and those who tested twice with a level of higher than 70 received performed like panenteric capsule endoscopy or ileocolonoscopy, and those that were not identified to have CD-related mucosal changes, they were characterized as at risk to develop Crohn's disease, and they were randomized to receive either tasty and healthy diet or habitual diet for 8 weeks. There was a crossover design, so people received the one diet after the other. So half of them were randomized to take initially tasty and healthy, and the other half to start with habitual diet, and they were measured fecal calprotectin every 4 weeks. Interestingly, in the group which started with tasty and healthy, you can see a significant drop of fecal calprotectin at 4 and 8 weeks, and there is a non-significant but trend of rebound straight after at 12 and 16 weeks as people move on to the habitual diet. And again, if we look on the vice versa, as there was a crossover study, we can see that people who started on habitual diet seem to have high levels of calprotectin at habitual diet. There is, though, a lot of variation and a drop here before people take the tasty and healthy, and then when they move into tasty and healthy diet, their levels remain down here low. So I think there is interesting data here to show that people have higher levels of calprotectin when they are on the habitual diet, and I think we might want to wait and see full data and publications. Though, as I said before, the momentum about prevention of disease is there, and we'll look on all these things more and more. There was at the same time a cohort study which presented the likelihood of development of IBD among 100 mother-child pairs who were enrolled in a study, in a Danish study. So we see here in those 100,000 mother-child pairs, mothers were interviewed during the first trimester, and then they were asked a food frequency questionnaire in order to identify whether they are having a diet high in ultra-processed foods. So the researchers have used the classification of NOVA, and then they followed after childbirth, they followed the offsprings from 0 years to 18 years old. And in this study, researchers identified 60,000 mother-child pairs who had enough data to analyze for UPF intake and likelihood of development of IBD, and this is a UPF intake during pregnancy. You can see that overall 20% of the calories of those mothers during pregnancy was covered from UPF, and you can see here the 3 groups of receiving smaller, larger and larger amounts of UPF as percentage of their daily intake. The group who received more UPFs had a diet lower in protein, had also a diet which was lower in fiber, and a diet which was much higher in sugars, and the diet quality was lower in those receiving a lot of UPFs. There were low numbers of IBD diagnosis. About 0.3% of the offsprings developed IBD, but interestingly, although the diets were very different between the 3 groups, there was no difference in developing in the rates of developing IBD, Crohn's disease, or ulcerative colitis. So here the UPF intake during pregnancy doesn't seem to be correlating with the likelihood of the offsprings developing the disease. And very briefly, As diet and nutrition is growing more and more within ECCO and in IBD, and we look more and more about the role of diet, not only as a factor of preventing disease, but as a factor of treating disease as well. I just wanted to present that there are a couple of very interesting presentations where diet was included as part of the treatment algorithm in IBD. So there was an update about the ECCO-ESPGHAN CD pediatric treatment guideline, the 2026 update, and you can see that nutrition as an induction therapy, either as exclusive enteral nutrition, which has traditionally been there, but also the use of CDD and PEN was described, especially for those with low risk disease. And you can see in a couple of clinical scenarios in patients who are at high risk, dietary therapy is mentioned as a bridge or adjunct therapy while waiting for a top-down anti-TNF biologic therapy. Again, here both EN and CDD-PN being acknowledged, and also in low-risk cases, EN or CDD and partial enteral nutrition is considered as an induction first-line therapy. And also there was a mention about the use of nutrition in preoperative optimization in children. Lastly, there was a presentation about the ECCO consensus on diet and nutrition in IBD by myself within the DECO workshop, and this was about the recent ECCO consensus on diet and nutrition. Very interestingly, at the conference it was presented that the ECCO consensus is one of the most downloaded papers within JCC, so there is a lot of interest about diet and nutrition out there. And I will for the sake of time, I will briefly mention 2-3 important points to keep from this consensus. In the absence of specific dietary interventions that are recommended by any of the IBD healthcare professionals, IBD patients should follow the healthy eating guidelines, and these should be as they are recommended for the general population. So if there is no indication for any specific intervention, we should keep in mind that our patients should be eating a healthy diet similar to the general population. And all people with IBD, is important to have access to a dietitian with experience in IBD. And this graph that is part of the consensus on diet and nutrition is a graph which is putting together all the new guidance that we get from this consensus, the use of EN, PEN, or CDD and PEN in Crohn's disease in order to, as agents alone or with others in induction of remission, and the use of supplements like curcumin and king dye in ulcerative colitis. When it comes to maintenance of remission, partial enteral nutrition for Crohn's disease, or the use of curcumin, Mediterranean diet, and red and processed meat reduction for ulcerative colitis are important to keep in mind. A lot of different guidance here for different comorbidities. I think it's important to remember low FODMAP diet for IBS-like symptoms, exclusive enteral nutrition for Crohn's disease complications, especially strictures or preoperative optimization, and the role of fermentable fiber, Mediterranean diet, and daily fruits for pouchitis patients, and some information about nutritional assessment and optimization, which is focusing on the screening and the use of global nutritional body composition assessment in routine care. And lastly, information to keep in mind about prevention of IBD. There is guidance in the consensus about reduction of risk overall in IBD with a healthy eating diet and fiber intake, reduced risk of Crohn's disease when people are eating higher amounts of fruits and high fiber breads, zinc and DHA, and higher risk of Crohn's disease when people eat more ultra-processed foods. And lastly, in ulcerative colitis, there seems to be a preventative effect of high fiber cereal, a high N3 to N6 ratio of polyunsaturated fatty acids, oleic acid, vitamin D, and DHA, while high amounts of arachidonic acid seem to be increasing the risk of ulcerative colitis. Thank you so much for the time and opportunity to talk about diet in IBD here, and more than happy to answer any questions.
Thank you so much, Bios. Beautiful presentation and hot topic. Bea, do you want to comment something? I know you're much into diet. I'm sure there are lots of things to discuss. I think Seb already started some polemic
Yes.
there discussion, but do you have any
Seb
comments or
already
questions?
studied a question which I was also answering, but I think we can discuss loud voice. And there is something, Vayos, that I always ask myself when we do these studies on the mothers and what they eat and so on, is the fact that you will expect mothers feeding their kids as they do eat, right? So if they are eating very high ultra processed foods, you will expect their kids to follow the same dietary pattern, or if they eat very low fiber. And so I'm always missing whether we are doing the good analysis. It is the mother that is eating this. Of course, that may affect the microbiome, but also those kids will be fed the same way. So it's always difficult, right, to extrapolate things because some things occur in between families, and you will expect other kids, non-IBD affected, to follow the same diet, but they are not affected with IBD. So you see, it's somehow difficult.
Absolutely. I think this is a significant confounder, and a lot of the studies are not measuring this, are not assessing this. And I think we should have better designed studies which are assessing both the diet of the mothers during pregnancy, potentially the diet of the mothers before pregnancy as well, and then also follow up with diets of the offspring. Because again, if this is very different what the mother is eating, this can be affecting the final outcomes. To be absolutely fair, though, if you look at the methodology of these studies, apart from this very important point, I also very much worry about the methodology that we use in order to measure ultra-processed foods.
Yeah.
I think UPFs, are talked a lot more about over the last years, but all the studies we have done and developed over the past years have used tools which are not made and validated to measure UPF intake. Okay, the NOVA classification that we are using to define this is a classification which came later than a lot of these cohorts happened, and a lot of this data were collected with different tools which are not actually assessing exactly the right thing. So I think we need more information there. We need bigger studies, more studies, and of course accounting for all these confounding factors will be a very important way to get more ideas, and obviously to design interventions. I think interventions about prevention are taking all the glory these days, and we will soon have, I believe, more interventions either in pediatrics or in adults about preventing the disease. And these are big, expensive, and important studies to do, and I think it will take some time to have more data on this.
Yes, and Seb was asking on the group. I don't know if you have seen the question, which I think he's raising a good point. So he suggests that we have seen that this is not working as good as we expected, especially in adults, and he wonders whether this is because we need long-term studies, which I believe we will need, but this may be super expensive. The lack of sham-controlled dietary studies, and also the adherence problem with diet, and I would like to hear your thoughts on this.
I think this is all super valid comments. I think there is data and comparative studies data there to show that compliance is a big issue. And I think we haven't had great studies in the past to show efficacy of several dietary approaches, mainly because we haven't had good
A
adherence
gente
and compliance.
planeja uma coisa, vamos ver. É que tem que ver onde tá. Depende muito. Tem que baixar ela só. Depende muito dos achados, porque ele falou que era reto.
Poliana, could you please mute yourself?
Okay, lovely.
Sorry for that.
That's fine. So yeah, I think we are missing good compliance studies. On the other side, like coming from the clinical experience side, when we are missing the guidance, it is a little bit tricky, to increase compliance, and the way we position those therapies in clinical practice is very much affected by this doubt on whether the diets are working or not in adult populations, for example. At the same time, we do need better designed studies to prove that we can use those trials as induction therapies. But I totally agree with Seb. we do move away from using the dietary therapies as induction therapies. And if we look at the new way we are using enteral nutrition, either this is to support biologics, to pre-optimize people before surgery, or to further decrease the inflammatory burden along with other drug treatments, I think this is where we are moving to. This is where we need better design studies, and I think we are getting them, because when we use the diet along with biologics or in other interventions, we have better defined clinical outcomes, and we can show the significant adding efficacy of the dietary therapies there. And as we will, I don't think we will be going back anytime soon in de-escalating from using early therapies, because these are really changing the root of the diseases and how people are getting better, and in a top-down approach. I think it's very important to explore better where diet fits in all these. And I think it won't be the induction therapies, it will be other ways of using the dietary therapies to better improve outcomes.
I think we had Nathan there. I can make you a short question, Bios. How do you use partial enteral nutrition in practice? Because that's something we all have available, and I'm afraid we're probably not using it enough. Any practical tips for those of you that don't have a dietitian at hand? It's many of us, and especially in small hospitals around the world. How would you recommend to do it in a practical way?
I think first of all, partial enteral nutrition is a great treatment to use, because it's very easy for patients to comply to. And I'm saying very easy there, but it's a much easier diet to follow compared to exclusive enteral nutrition. And either in adults or pediatrics, we use it in a different number of occasions. Partial enteral nutrition is given orally to most of our patients, and they are able to consume it. We are using obviously polymeric feeds, which are very much better palatable than anything else. And we do use it either along with the Crohn's disease exclusion diet, which is a very specific protocol for a period of 6 weeks to decrease the inflammatory burden of the patients. Either this is used as induction therapy or along with other treatments. But even itself, partial enteral nutrition can be used during the induction phase or the maintenance phase, and again, as an adjunct to the drug journey. So in my clinical practice and in collaboration with the physicians, we will use it whenever we want to reinforce the top-down approach, like whenever we want an extra weapon to hit the inflammation. And I think we will use more and more about this, either to optimize biologics, like as a combination treatment there, like the study I just presented. I think there is a growth in the data coming from this area, and there will be a lot of studies in the next couple of years published about the added efficacy of partial enteral nutrition added in a biologic. And of course, preoperative optimization has a lot of value there, either if EN is used exclusively or partially, if exclusively is not possible.
Thank you. Nathan.
Just to finish the comment on Seb's remark, what I don't know what you give as an advice for like general population diet and the definition of healthy diet that you tell your patients, but I think it is difficult to explain. We all know that Mediterranean diet is a healthy diet. We all know that an apple is better than red meat, but in everyday life, it's difficult for patients and for general population to have enough information and to have a good education on what is a healthy food. And in France, I know it's not in general countries in Europe, but I think for me, sometimes I'd give some simple advices using Nutri-Score or that kind of easy way to evaluate for patients or healthy patients to assess if food is good or not. And actually, there are data on the Nutri-Score and the risk of later Crohn's disease. And for me, just to give simple advices on how to choose food in the market. Sometimes I'll tell a patient that Nutri-Score could be good to choose what to buy in the market. I don't know what you use and what advices you give for your patients and what bios.
So do you mean about, are you thinking are patients with IBD, or are you thinking
in general? No, in general population and.
There is no specific validated tool that measures factors which are increasing the risk of inflammatory bowel disease. However, in the recent consensus, we have identified several dietary factors which are important in increasing the risk. I think a diet which is high in fiber and a diet which complies, better in Mediterranean diet, so a diet rich in fruits, vegetables, nuts, legumes, and seeds is very important in order to prevent IBD overall. There are a few differences between Crohn's disease and ulcerative colitis. There seems to be more kind of weighted impact of omega-3, for example, omega-6 ratio for ulcerative colitis, and studies about UPF, which are coming up about Crohn's disease. But again, this is a lot about what kind of data we have available, what people have tried to study within those cohort observational studies. I go back to explain what is a Mediterranean diet, what is healthy eating, and something important in the dietary practice here is to remember national healthy eating guidelines. It will be very difficult to feed the Mediterranean diet to everyone in the globe, but it will be very easy to advise people to go back to the healthy national guidelines, whatever they are in a country, and try to get people to stick to a healthier diet. If I had to, keep few things, I would go back to fruits, vegetables, legumes, nuts, and seeds. I think a plant-based diet to a high extent, without it being vegetarian or vegan, is what we call a Mediterranean diet and what we would use in order to prevent, the risk of offsprings developing IBD or other diseases. Okay, because this is very similar in other scenarios, and I think having in front of you someone from the general population means you want to help them have good health in all aspects.
Thank you, Bios. We have a question here also regarding the practicalities of pen.
Yeah.
So, what formula, what amount, how long? Do you do any restrictions also in the diet while you introduce the partial enteral nutrition? Is there any comment on how to, because there's here what components minimum and what formula, or if there's any, or how do you do it in practice?
Good. I think this is a great question. Preference of formulas. So polymeric always, unless for some reason it's contraindicated. There are some formulas which have been used and studied more than others in the past, but actually there is evidence to say that there is a lot of different formulas which can work in similar ways, and most of the enteral nutrition feeds sharing similar characteristics are gonna work in a similar way. Like we've previously published with Professor Gerasimidis from Glasgow, a study which showed that over 50 different feeds are actually having similar efficacy in exclusive enteral nutrition, and seems to be that there is not a magic trick in there, and might be more about the exclusion rather than the inclusion in this therapy. Now, when it comes to other components, when we couple PEN with CDD, there is obviously the limitations of the diet per se, and actually its inclusion of specific foods along with PEN. In this case, people will use a lot of chicken, potatoes, eggs, bananas, and apples, and a number of other foods. But this is the main thing which is covering the calorific intake for the period of this 6 weeks. When we use PEN itself, No, we don't limit anything else. People are on a free diet otherwise, unless there is limitations we should enforce, like if there is structuring disease, we will looking into body physiology, gut physiology, we will restrict fibers for reasons which other than disease activity. The only important thing to think about PEN is the more, the merrier. The higher the amount, the higher calories we are covering, the better the outcomes is, both when we use it to support induction and when we use it to maintain remission. There are meta-analyses recently to show that if we cover more than 33% of the calories, then it can support induction or maintenance. If you cover less than 33% of the calories, doesn't seem to be doing anything. So what we did in the past and said, why don't you keep drinking one glass of this after you completed the EN, doesn't work and no point to do it. Either you cover at least 1/3 of the calories or no point to be doing it, and you can, no need to prescribe or get the patients to keep drinking it. Higher than 50% should be better. We need more studies to better define the dose dependency and what cutoff we should cover for better outcomes. But obviously we have data to say that 50% is a good enough strategy to support maintenance of remission.
Good point. Good point. Let me see. Is there any other questions from the floor or? Because let me see. I don't see anything here.
Darius, I only wanted to say, so I always wonder, because the situation with the diet in IBD, it always intrigued me how we are pushing so much, and Seb was pointing this as well, once the disease is diagnosed compared to before it's diagnosed. And we will all agree that the dietary habits that we recommend for healthy population to prevent IBD is the same that you will use to prevent cardiovascular disease, the one you will use to prevent colorectal cancer, the one you will use to prevent so many other things. And because there are so many diseases that are related to how we eat and and the lack of exercise, of course, as well, and so on. One wonder why we are not pushing further the restrictions on and the prices of ultra processed foods and so on. And I'm talking about Spain, and I assume it's the same case in Greece. I'm not sure, but definitely in Spain, most people think they eat Mediterranean food, and I will say almost no one does. Because the amount of, not only the amount of ultra processed food, but the amount of red meat is just because of that. And you can follow with the amount of fish that they eat is very low, and the amount of legumes is very, very low for our countries. And we are talking about Mediterranean countries. Now go, let's say, up north in Europe or somewhere else where there is no the culture of this sort of eating. So it's becoming very complicated.
Oh, absolutely. And I was actually doing a presentation the other day about pediatric obesity, and I was looking at the shift of people from the Mediterranean diet in the Mediterranean elsewhere. And we have actually the Mediterranean countries like Greece, Spain, Italy, Turkey have shifted the most away from the Mediterranean diet. Yeah. And this shift correlates really well with the percentages of obesity, type 2 diabetes mellitus, and a lot of other things over the past few years. So people are not eating a Mediterranean diet. The Mediterranean diet is really a plant-based diet. Like the Greek traditional Mediterranean diet with the Greek Orthodox Lent meant that people would eat a vegan diet for about half of the year, 170 roughly days. Okay, and this is a religious thing which led to how people ate over the years. And then it is a heavily plant-based diet with a lot of obviously fruits, vegetables, legumes, seeds, and nuts, plus lower amounts of meat. I think we need public health interventions for this, and I think these need to be informed not only for the very important cardiovascular diseases, but also for the prevention of autoimmune diseases. And I think we talk not enough about fiber to our patients. We talk not enough about healthy eating to our patients. And as we have data now about prevention of those diseases, I think also we need to raise, we don't talk enough to our IBD patients about the risk to their offsprings. and about dietary education for the families about this. We are doing a study right now in Greece where we ask people whether they think diet is an important contributor to their first degree relatives developing IBD, and half of the patients are not considering this is something important. Like they are considering psychological factors important, medications important, family history important, but they don't think what they are feeding their children will affect their chance to develop IBD. And I think we should inform the patients better. Obviously, we need the evidence to do that. But I think we are in a stage now that we have guidance, we have couple of papers like consensus and guideline papers talking about foods associated with higher risk, and this is something we should implement more in our consultations with patients as dietitians and physicians in order to inform them on how to reduce the risk.
Thank you.
Thank you, Bios. Yeah, very interesting discussion. I think we have a lot of things to cover. I also wanted to ask some more things about the alpha V beta 6 to Maya maybe later, but we can have it in another conversation because this is it's super interesting. I mean, the accuracy that it has and how it can predict. And also we have a positioning. We had some things about the stricturotomy that I'm also curious if you're using or not, but maybe we can have it in another conversation because I think we've been 1 hour and 20. The speakers have been super in keeping the time, and we haven't been as usual, but I think it's nice to give freedom and have it a bit of a relaxed session. I would keep on talking about that, but I know that we are all busy and things to do, family, etc., and it's late in the evening. So thank you very much for joining. Thank you very much for making this community a real thing that is growing and with a lot of possibilities and beautiful people. Thank you very much, Bea, for joining and moderating, and to the Yogi board. Some of them are here present and some of them couldn't do it today. So I think we close it here. Thank you very much for joining, and let's keep in touch and let's keep on discussing and learning from each other. Thank you very much.
Thank you all so much. It's been great seeing you all.
Thank
Thank you.
Thank you, Maya,
Thank
Bios, and
you.
Nathan.
Thank you very much.
Bye.
See you in
Thank you very much.
Cartagena. See you in Cartagena, Colombia.
See you soon.
See you guys.
See
Saeb, good to see you. Thank you very much for joining and taking the time.